Dysfunctional labor and delivery, adverse effects on offspring. A presentation of the American Journal of Obstetrics and Gynecology. Although there is no doubt that labor and delivery can sometimes produce fetal and neonatal adversity, the frequency with which this occurs is uncertain, particularly in modern healthcare settings. This is an important issue because, if being born after a prolonged or neglected abnormal labor does confer risk, then prompt diagnosis and evidence-based management of abnormal labor is of great consequence, and discussions about how best to recognize dysfunctional labor are quite relevant to everyday practice. There are substantial challenges in the epidemiologic study of the effect of parturition on offspring. Randomized trials would be ethically fraught. Therefore, large observational samples with detailed data concerning labor and delivery events, as well as long-term follow-up of babies, would be necessary to reach solid conclusions. Few such data sets exist, and it is difficult, expensive, and time-consuming to create and to study them. Reports of immediate newborn condition in relation to the antecedent labor are helpful, but these measures are imperfect predictors of long-term neurologic health. Moreover, it is uncertain what the best diagnostic tools are to detect childhood handicap with a perinatal source. There has been a paucity of research in this area, and most published studies did not ensure against confounding by the many comorbid and intercurrent events and conditions that may have affected outcomes measured distant from birth. An exception to these concerns were the data derived from the National Collaborative Perinatal Project sponsored by the National Institutes of Health. Detailed data on labor course and outcome were collected from a sample of about 18,000 deliveries between 1958 and 1974 from 14 U.S. hospitals. These data have been analyzed exhaustively and include a cohort of children followed for 7 years after birth. While unique in the thorough follow-up of children born to study mothers, legitimate questions about the current validity of the Collaborative Perinatal Project results can be raised, considering the substantial changes in obstetric and neonatal care that have occurred since the data were collected. This reservation notwithstanding, the data demonstrate remarkably uniform relations among several measures of outcome, including perinatal mortality, APGAR scores, speech, language, and hearing abilities at age 3, intelligence quotients at 4 and 7 years of age, with the events of labor and delivery. The great majority of babies born after a labor complicated by a prolonged latent phase do well, and this disorder was initially thought to be innocuous. However, there is evidence that there is a significantly worse perinatal outcome after labor is complicated by a prolonged latent phase than after a normal labor pattern. Data from the National Collaborative Project showed significantly increased relative risks for stillbirth, neonatal depression, abnormal speech, language, and hearing at 3 years, and low IQs at 7 years old. Several kinds of analysis support the view that both protracted active phase dilatation and protracted descent are associated with adverse fetal and neonatal outcomes. Associated perinatal mortality rates are threefold higher than after normal labor, and poor long-term outcomes, including abnormalities of speech, language, or hearing at age 3 and lower IQs at age 7, to be more than twice as frequent. The relative risk for composite perinatal morbidity and mortality in the collaborative project was 2.12, a significant figure. Unfortunately, no recent studies addressing this issue have been published to provide further insights. Increased rates of perinatal deaths and morbidity in association with arrest disorders were also documented in the perinatal project. The relative risk of perinatal deaths found in association with arrest disorders of labor was 7.5 and was even higher in later studies. In parallel with the mortality risks, several investigators found a strong relationship between arrest patterns and reduced performance on childhood neurologic and cognitive testing. A large case control study found nearly 3 times the frequency of arrest of labor progress among developmentally abnormal children. Of particular interest is that stratification by delivery method showed that vaginal delivery after an arrest disorder magnified the poor infant results, whereas cesarean delivery diminished the impact attributable to the labor disorder. When logistic analytic methods were brought to bear to assess the impact of arrest disorders while other factors were taken into account simultaneously, the adverse perinatal effect was greatly diminished. Based on these findings, one could conclude that much of the fetal danger associated with arrest disorders is subsumed by other factors acting simultaneously. These probably include oxytocin use, the presence of cephalopelvic disproportion, and the timing and type of delivery intervention taken to address the labor problem. In addition, the duration of the arrest pattern may play a critical role in this regard, as evidenced by the correlation between longer arrest periods and more intense and prolonged adverse effects. To summarize and conclude, dysfunctional labor patterns, objectively defined, are potentially associated with poor outcomes for surviving infants. This adversity is influenced substantially by the delivery method. Whether these effects can be mitigated by early diagnosis and management is uncertain, but available data suggests they can. Most babies born after a prolonged latent phase do well, but this disorder is associated with significantly worse perinatal outcome than after a normal labor pattern. Both protracted active phase dilatation and protracted descent are associated with adverse neonatal outcomes. Increased rates of perinatal deaths and childhood neurologic and cognitive disability in association with arrest disorders have been documented. The direct relationship between the duration of arrest disorders and the risk of neurologic or cognitive disability indicates the importance of prompt recognition and management of abnormal labor progress. Definitive answers regarding the potential adverse effects of labor will require further sophisticated investigation. The issues are complex, and the inability to isolate labor's specific contributions to outcome hinders interpretation of most observational studies. It may be that when difficult instrumental delivery is avoided, and dysfunctional labor is managed according to uniform and validated protocols, risks are minimized. This may explain why some contemporary data make dysfunctional labor seem less sinister than did earlier work. Widespread use of labor curves to monitor progress may have reduced the number of dysfunctional labors that could lead to fetal injury to persist unrecognized.